My name is Hannah. I am currently undertaking the Masters in Advanced Clinical Practice. I am a registered nurse by background, having qualified in 2010. I am currently working in a city centre based urgent treatment centre. I've worked here for the last 7 years. Over this time, the service has changed from a walk-in centre to an urgent treatment centre with X-ray facilities. It is a clinician-led service consisting of a small team of advanced clinical practitioners and a larger team of clinical practitioners, including nurses and paramedics. We have a non-clinical director who is a GP. This presentation is going to look at my changing role from a trainee to a qualified ACP within the Urgent Treatment Centre. It will look at this at the macro, meso and micro levels. The NHS was founded in 1948 in order to offer free healthcare to all. It has evolved over the last 80 years to keep up with an ever-changing world. The NHS has been and continues to be under significant pressure due to an ageing population, workforce shortfall, and an increase in healthcare costs. Fothergill, 2022. Over the years, there have been various NHS policies drawn up in order to improve healthcare in the UK. In 2014, the NHS 5-year forward view set out to improve urgent and emergency care in the UK. It acknowledged that the NHS was under greater pressure than ever before, suggesting that the NHS provides over 20 million emergency type visits per day. Some of these visits could have been seen and completed in other areas of the urgent treatment system. This increased pressure in the emergency department led to a decline in the 4-hour target for treatment being met. In order to ease the pressure of the urgent and emergency care system, the 5-year forward view set out some key ideas and targets. This included the rollout of more standardised urgent treatment centres. These would give patients access to care that was deemed urgent but not needed to be seen in the emergency department. The 5-year forward view has been superseded by the NHS long-term plan in 2017. The drive to educate patients to only attend A&E if it is a real emergency, as well as the setup of the urgent treatment centres, has led to a slight decrease in emergency department attendances, while attendances within other areas of the urgent treatment system, including urgent treatment centres, has increased. NHS Digital 2018. The NHS long-term plan also acknowledged that the NHS workforce growth had not kept up with the needs of the service. This has led to a significant shortage in the workforce. The report highlighted that one of the main reasons staff were leaving was because they did not get the support for career progression. They made a commitment to support career progression and for practitioners already working in the NHS to be recognised for their unique skill sets. These key policies have highlighted the need to encourage advanced roles within healthcare, which can contribute to the ever-changing NHS. So what is an ACP? Advanced practice roles were first developed in the UK in the 1980s and they have continued to evolve ever since. Historically, there has been no regulation or even a clear definition of what an ACP is within the UK. Unlike other countries such as America, where the advanced practitioner role is protected and regulated, this lack of regulation has led to various professionals using the term to cover varying roles and levels of education. NADAF 2018. In 2017, the development of the multi-professional framework for advanced clinical practice in England led to a standardised definition of the role of an advanced clinical practitioner. Health Education England defines the role of advanced practice as seen on this slide. A recent relatively large study by Fothergill 2022 concluded that even though there is a standardised definition of advanced practice, in reality there is still a variation in the role title and scope of practice across practitioners working in England. The study also highlighted the inconsistencies in the level of training and support given to trainee and qualified ACPs. One study found 595 different job titles describing advanced and specialist practice. Evans 2020. McKenna 2006 argued that the ACP role has been developed as a cost-cutting exercise to bridge the gap in the shortage of medics. Delamere and Lafortune 2010 proposes that there are a number of reasons for promoting the advanced clinician role, not just to fill the gaps in the workforce, with the main reasons being the changing patient needs and increasing access to services. During the transition of my workplace to an urgent treatment centre, it has gone from a walk-in centre seeing primary care issues to a doctor-led urgent care centre and now to a clinician-led urgent treatment centre seeing both minor illness and injury. I started there as a Band 5 registered nurse when it was a walk-in centre and have developed my career up to a trainee ACP. This fits in with the NHS plan to upskill workers and promote advanced practice. But am I a cheaper replacement for a doctor? Professional identity can be described as a set of values and beliefs that shape the conduct of individuals within a professional group. Anderson 2019. It is critical to safe and effective clinical practice in healthcare professionals. Matthews 2019. It can be described as a continuous journey by which individual and professional identities merge. As a registered nurse, my professional identity started to develop during my time as a student, developing throughout my career based on my experiences and my career progression. Philippa 2021. Wood 2020 acknowledged that nursing has a strong professional identity and sense of belonging. This could be partly down to being regulated by our governing body, the Nursing and Midwifery Council, which sets out clear guidance on what a nurse can and cannot do. Matthews 2019 supports this by highlighting that professional identity defines practice boundaries and helps limit role confusion. Prior to starting my ACP training, I had been working as a nurse for nearly 10 years and had a senior role within the department. I felt accepted and respected in this role. Now as a trainee ACP, where do I fit? Junior nursing colleagues no longer see me as a traditional nurse, yet I do not see myself belonging to the group of advanced clinical practitioners. It can be argued that advanced practice sits somewhere between nursing and medicine, which is why it can be hard to develop a professional identity and a sense of belonging. Kulak and Gagnon 2016. A lack of understanding around the knowledge and skills required of an ACP and the blurring of professional boundaries can contribute to a misunderstanding of the role. Griffin 2006, Thompson 2021. This lack of understanding can affect how other professions, but also how the public and patients view the ACP role. The evidence suggests that most patients are happy with ACP-led care, with the ones that are less happy having a lack of understanding of the role and what ACPs can do. Evans 2021. The unit where I work, we are run by clinical practitioners and ACPs on a daily basis. We have no medical staff on site. This has presented as a problem in the past when we have had to liaise with other professionals, especially doctors within the acute hospital setting, when trying to admit a patient into their care. This again could be down to a misunderstanding of the role of the ACP, or it could stem from the historical hierarchy in medicine by which nurses are seen as inferior to doctors. A study by Ewell in 2018, which evaluated a sample of 25 AMPs working in out-of-hours urgent care services, highlighted that they often face a negative perception of the ACP role from medical professionals, who often undermined their autonomy and put up barriers by asking questions such as, has a doctor reviewed the patient prior to them referring? This is a question that I have come across multiple times in my career. As a service, we have worked hard to break down the barriers, and more recently, the Acute Trust senior doctors have been more accepting of our referrals. This may be down to the fact that they themselves have been promoting the ACP role within their own directorates. Therefore, they have a better understanding of this and the strengths and limitations of the role. This difficulty in developing a professional identity and the confusion of the role of the ACP can have a significant impact on the confidence and development of the trainee ACP, leading them to feel as though they don't belong and are of little value within the service. Matthews 2019. Anderson 2019 discusses the importance of group membership and that being part of a group boosts one's self-esteem. I do feel that I have the support of my ACP colleagues and hopefully will be accepted into their group as I progress on my ACP journey, but as an organisation I feel there is a lack of understanding of the role. The ACP role is fairly new within our service, having been implemented in the last 5 years. Urgent Treatment Centre Manager is also not an ACP by background, so again, I feel that he does not understand the complexities within the role and does not always advocate our needs to the senior management team. It is well documented that occupational stress is high amongst healthcare professionals, PEACH 2018. Research suggests that over 70% of nurses demonstrate high stress, Faraji 2012. There are various factors that affect this: an increasing workload, staff shortages, and organisational issues, to name a few, and not forgetting the COVID-19 pandemic, which has placed an unprecedented amount of pressure on healthcare professionals and services over the last few years. These pressures can lead to burnout and result in a high turnover of staff. This is something we need to be aware of when progressing into the role of advanced practice, where we'll often be taking on more responsibility and accountability in line with the 4 pillars of advanced practice. These pressures have been evident in my workplace over the last year, where there has been an increase in workplace stress due to an increased demand on the service, an increased level of sickness due to isolation and COVID-19, which has led to us losing approximately 1/4 of our clinical team. This in turn has put an increasing pressure on the remaining staff to continue performing to a high level whilst under extra pressures, all the time ensuring we work within our professional boundaries and regulations. In summary, the NHS continues to adapt to an ever-changing world. It is committed to reducing emergency department attendances and is promoting other urgent care pathways. The development of the ACP role will play a key part in this, as ACPs can provide adequate, advanced level care to help patients have easier access to healthcare in a timely manner. Moving forward, the ACP role needs to be protected as it is in other countries, providing practitioners with a clear set of guidelines and allowing other professions and the public to gain trust in this role. This would also allow organisations to understand the continuing learning needs of the ACP. It is important to ensure that ACPs are supported in their roles and not expected to work beyond their scope of practice, and that they are not facing high levels of stress which can lead to burnout. Personally, I feel that as I move through my ACP training, I will find my feet and my professional identity with the help and support of my ACP colleagues. Together we will strive to build a service that is respected by other professionals and patients so that we can work in unison, providing a safe, easy to access service. The next slides contain my references.